Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the human heart valves, diseases and management. The valves of the heart are mitral valve, aortic valve and pulmonary valves, and the frequency of the disease also in the same order. Syphilis causes aortic regurgitation secondary to the dilatation of the aorta. Congenital lesions are responsible mainly for pulmonary valvular disease. Some cases of aortic disease and occasionally for tricuspid disease. If infective endocarditis is superimposed on congenital or rheumatic lesions and causes further damage. Rheumatic fever is responsible for most cases of rheumatic valvular diseases. Rheumatic endocarditis leads to inflammation, thickening, fibrosis and deformity of valve cusps, chordae tendineae and the valvular ring, leading to imperfect closure and narrowing of the valve. Adhesions of the cusps, rigidity and calcification may lead to narrowing called buttonhole aperture. Shortening of chordae tendineae give the shape of funnel, so further increase the narrowing. Mitral regurgitation. Most cases of mitral regurgitation results from rheumatic fever, rupture of chordae papillary muscle, erosion of a cusp by infective endocarditis or widening of the AV ring from dilatation of the left ventricle or papillary muscle, sometimes congenital malformation. The left atrial volume increases with ventricular systole and the left ventricle is overfilled during diastole, but output per beat into aorta is unchanged till the left ventricular failure develops. Symptoms of mitral regurgitation. Till the left ventricle compensate for increase in diastolic volume, no symptoms are produced. In severe cases, symptoms are developed. A pan-systolic murmur maximum at the apex and conducted towards the left axilla and accompanied by a thrill. The first heart sound is either absent or weak. The left atrium is enlarged, confirmed by the radiograph. The left ventricle is enlarged and felt at the apex of the heart as a thrust and also confirmed by X-ray. The left ventricular hypertrophy is shown by electrocardiogram. Treatment of mitral regurgitation. The treatment option is the surgical. The valve can be repaired, but a prosthesis is usually required. Open heart surgery is necessary. Mitral stenosis. In mitral stenosis, pressure in the left atrium is raised and leads to pulmonary venous hypertension and congestion and leads to hypertrophy, dilatation and failure of right side of the heart. Atrial fibrillation is the common complication. Symptoms of mitral stenosis. Dyspnea develops due to congestion, increase in work of breathing. Acute pulmonary edema may occur with exercise, emotion or atrial fibrillation. Palpitation is distressing, causing cough due to pulmonary congestion. Hemoptysis may occur due to rupture of bronchial veins or from pulmonary infarction. Pulmonary and systemic embolism is the important complication. Treatment of mitral stenosis. Surgery is the only way for correction of the stenosis. Mitral valvotomy reduces the back pressure on the lungs, and pulmonary congestion alleviates dyspnea due also permits a greater increase in cardiac output on exertion. The degree of mechanical obstruction is at the mitral valve is rarely the factor of importance in mitral stenosis. The amount of myocardial damage, other valvular defects, narrowing of pulmonary arterioles, and changes in the lungs due to prolonged congestion contribute to overall situation. The suitable patients for operation are those with uncomplicated mitral stenosis in sinus rhythm, less enlargement of heart when there is a considerable disability or evidence of progression of symptoms and signs. Pulmonary edema and hemoptysis are the strong indications for operation. Some patients may require a second valvotomy for restenosis. If the valve is severely damaged, it may be replaced by a prosthesis. Aortic valve disease. Aortic regurgitation. Majority of cases are due to rheumatic fever. Others may be due to infective endocarditis, syphilitic aortitis, congenital malformation, or trauma. Mild regurgitation may be due to hypertension or atherosclerosis of aorta. In rheumatic cases, there is a thickening and shortening of cusps, and stenosis often coexists. Syphilitic aortic regurgitation results from dilatation of aortic valve ring. Symptoms of aortic regurgitation. The compensation may be excellent for many years. In time, left ventricular failure occurs and progressive dyspnea on exertion is soon followed by paroxysmal dyspnea at rest, followed by orthopnea, and finally right ventricular failure. Diagnosis of aortic regurgitation. High-pitched blowing, early diastolic murmur commencing after the second heart sound and best heard down the left sternal edge. Using a chest piece firmly applied with the patient standing or sitting, and breath held in expiration. A systolic murmur from the increased stroke volume is a common accompaniment. Enlargement of left ventricle leads to displacement of apex beat to downwards and to the left, and to a heaving impulse. Low diastolic blood pressure with a high pulse pressure. Collapsing radial pulse, visible arterial pulsation in the carotid arteries, pink and warm extremities, and capillary pulsation in nail beds. Radiography shows the degree of left ventricular enlargement. Electrocardiogram shows the pattern of left ventricular hypertrophy. Surgery for aortic regurgitation. If there is a left ventricular failure or signs of left ventricular enlargement or hypertrophy, the valve should be replaced. Aortic stenosis. It may be due to the rheumatic heart disease usually associated with other valvular lesions, calcification of the valve, an aortic systolic murmur from the sclerotic valve without obstruction is seen in elderly. Symptoms of aortic stenosis. The symptoms depend upon the degree of narrowing, presence of lesions of the valves. Mild cases of stenosis are frequent but not recognized and in the compensated phase without any symptoms. In case of left ventricular failure, symptoms are those of regurgitation like progressive dyspnea on exertion followed by paroxysmal dyspnea at rest, orthopnea, and finally right ventricular failure. Faintness, dizziness, syncope, anginal pain on exertion are characteristic. Apical impulse is thrusting in quality due to the ventricular hypertrophy. A systolic thrill maximum in the same area as the murmur and transmitted into the neck is common but not invariable accompaniment. As with the diastolic murmur, it is best appreciated with the patient leaning forward and breath held on expiration. A harsh murmur maximum in mid-systole, best heard to the right of the upper sternum at right border or the apex. Aortic component of second sound may be faint or absent. An aortic diastolic murmur is often present without peripheral signs of free aortic regurgitation. Pulse of small amplitude and raising slowly to a delayed peak. Lowered systolic blood pressure and decreased pulse pressure. Left ventricular enlargement or hypertrophy may be confirmed by ECG or X-ray. Calcification of the valve may be seen on radiograph with the image intensifier screen. Treatment of aortic stenosis. When there are symptoms of left ventricular failure or signs of hypertrophy, or the left ventricular pressure is high with a large systolic gradient across the valve, 50 mm of Hg or more. Surgical treatment with replacement of the valve is advisable. Pulmonary valve disease. Pulmonary stenosis. Pulmonary stenosis is almost always congenital in origin and may be accompanied by ventricular septal defect, particularly as a part of tetralogy of Fallot. The features are a loud systolic murmur, thrill, and a right ventricular hypertrophy. A pulmonary systolic murmur from high blood flow across a normal valve is frequently audible in children, in pregnancy, and in hyperkinetic states, as anemia, thyrotoxicosis, or with a left to right shunt, particularly between the atria. It can be distinguished from that of pulmonary stenosis by the softness of the murmur and the absence of the right ventricular hypertrophy. Pulmonary regurgitation. It usually results from pulmonary hypertension, as in mitral stenosis. An early diastolic murmur is heard to the left of the upper sternum. Graham-Steele murmur. Dilatation of pulmonary artery and hypertrophy of right ventricular associated. Most diastolic murmurs heard in this area originate at the aortic valve and can be distinguished by the presence of other signs of aortic regurgitation. Tricuspid valve disease. Most cases of tricuspid disease are rheumatic in origin and associated with mitral stenosis and aortic valve disease. Tricuspid regurgitation also frequently results from right ventricular dilatation when this chamber fails due to pulmonary stenosis or hypertension. Sometimes it may be of congenital origin. Symptoms of tricuspid valve disease. Both tricuspid stenosis and regurgitation leads to the features of right-sided cardiac failure with jugular venous distension, enlarged liver, peripheral edema, and ascites. There is usually little dyspnea or orthopnea in spite of simultaneous mitral stenosis due to diminished output of right ventricle into the lungs. If sinus rhythm is maintained, there is electrocardiographic evidence of right atrial hypertrophy. Dilatation or right atrium can also be detected radiographically. In tricuspid stenosis, there is usually a prominent A wave in jugular venous pulse. Murmurs usually resemble those of mitral stenosis, being mid-diastolic and pre-systolic, but differ in being maximum at the lower sternal edge and increasing in intensity on inspiration. Tricuspid regurgitation shows a large systolic pulsation in the jugular veins due to backflow of blood during systole. The systolic murmur of tricuspid regurgitation is maximum at the lower sternal region and is accentuated on inspiration. The tricuspid valve disease, the signs are overshadowed by mitral or aortic valve disease features. Treatment of tricuspid valve disease. In severe cases, repair valvotomy or replacement may be necessary. At the same time, if there is a concomitant mitral valve disease, it also requires surgical treatment. That's all about the heart valve diseases, and in the next video I will discuss about some other disease. Thank you.